was established to support people in their journey with Lyme disease, either in themselves or in someone they care about. Our belief is that there is an interdependence of mind, body, and spirit in promoting healing. Also, we understand how isolating the journey can be, so we offer a community to be reminded that we are not alone. Tonight, I'd like to give a moment to the concept of service. Whether we realize it or not, and whether we conceptualize it as such, most of us are engaged in service to others on a daily basis, as a parent, sibling, friend, coworker, or any number of such roles. The word service might make us think of responsibility or work, and thus it may feel like a weighty concept. But opportunities to be of service are everywhere, not only formally, such as through a charity or organization, but also in situations that present themselves throughout the day. Doing a favor, being a sounding board, saying a prayer, helping a pet. Anytime we offer assistance to another living thing, we are engaged in an act of service. The assistance can be physical, mental, or spiritual, and there is no act of service that is too small or unworthy. It may often feel like a giving thing, but when we engage in an act of service, we receive so much. Studies have shown numerous benefits to such participation: decreased cortisol levels, reduced inflammation, increased energy, improved mental health, prevention of illness, and promotion of happiness are just some of the benefits we receive. Service feels good. And although we may not purposefully engage in such acts for our own sake, it is a huge corollary benefit. Like so many concepts that appear to be outwardly focused, but reverberate back energetically, when we engage in acts of service, we are actually serving ourselves with the most uplifting force. The poet Rabindranath Tagore put a beautiful spin on this truth with the following. He says, "I slept and dreamt that life was joy. I awoke and saw that life was service. I acted, and behold, service was joy." Tonight, we have Dr. John Aucott here to share highlights from his ongoing service to the Lyme community. We continue to be so grateful for his incredible efforts on our behalf. Our director, Gina Costa, will now share her welcome.
Thank you so much, Shireen. Welcome, everyone. Happy 6-year anniversary to the Lyme Care Resource Center. And special thanks to Phil and Shireen for establishing this nonprofit and for creating such a beautiful mission that has impacted so many incredible people over the years. I want to just welcome everyone, whether you're new to our group, whether you've been one of our long-timers. We're just so pleased for this collaboration and to provide support, education, and resources to all of you. I want to pull up a quote that I wanted to read to all of you tonight. I have 2 quotes that I'd like to share. The first one is about all the beautiful people in our Lyme community. The most beautiful people we have known are those who have known defeat, known suffering, known loss, and have found their way out of the depths. These persons have an appreciation, a sensitivity, and an understanding of life that fills them with compassion, gentleness, and a deep loving concern. Beautiful people do not just happen. Our whole team here at the Lyme Care Resource Center has experienced Lyme disease. We've gone through many different types of experiences, and we're very passionate about this nonprofit and the resources that we provide to our community. I think I wanted to share this quote because I know so many people can relate to it that experience Lyme. And as we learn how to respond and cope, and just when we think about how we face the unknown and the uncertainty and some of the setbacks that can be a part of the experience, it's important to think about the experience and what it means to us and how we can constantly reflect on it to develop strength and resilience. And, you know, my biggest message is to focus on the experience and try to keep a positive mindset and surround yourself with good people that are going to lift you and support you as you go through your journey. I put a second quote on this slide because I wanted to share something beyond the experience, something that's linked a little bit more maybe to action or to service, as Shireen just shared her beautiful welcome to everyone. So this next quote is by Helen Keller, and she states, "Optimism is the faith that leads to achievement. Nothing can be done without hope and confidence. And it makes me think a lot about just the idea of what are we capable of doing for ourselves? What are we capable of doing for our families? What are we capable of doing for our communities as it relates to service, servicing ourselves the best that we can possibly do, and knowing that the best that we're giving in any moment is enough, with a positive mindset, and thinking about what we can do for our families, even with setbacks and challenges, and ways to use our service to our community to lift us, to get creative, to think outside the box. And this quote also makes me think a lot about not only our nonprofit or our individual experiences with Lyme disease or tick-borne disease or the other challenges that we face in life, because it's never one thing with Lyme. It's usually a multitude of different kinds of challenges that we're trying to navigate through. But this quote really leads me into my introduction of this collaboration tonight with the Johns Hopkins Medicine Lyme Disease Research Center and all of the good work and service that they have done and are doing. And I think about just the collaboration tonight, and we're so blessed to have two members from their team. We have Nancy Doherty joining us tonight, and she has been a huge part of the center, and she's an invaluable resource, not only to the center, but also to our nonprofit. She's been with Dr. Aucott, helping him in spearheading the center's communication and outreach since 2013. And Nancy will help us moderate the question and answer session that's going to happen tonight after the keynote talk by Dr. Aucott. So as we go through the event tonight and you hear Dr. Aucott's presentation, please feel free to write into the question and answer feature on the event with any questions or comments that you have, and we'll get to as many as we can throughout the evening. I want to reflect back on this quote about optimism is the faith that leads us to achievement. I want to just say that when I think about Dr. Aucott, I've known him for almost a decade now as my doctor, as a huge supporter of this nonprofit, as an amazing, committed, dedicated professional in the community that really focuses on a sincere desire to help others and to make a difference. When I think about this idea of optimism and having faith, it's faith is believing in what we can't always see, and we don't know what the outcome's going to be. And when I think of the Johns Hopkins Medicine Lyme Disease Research Center and our years of experience collaborating with them, I think about optimism, I think about innovation, research, discovery, and change. And, I just want to say that above all, Dr. Aucott, thank you for preparing a presentation for our nonprofit and for our community. Thank you for your commitment. Above all, you're a visionary, you're creative, you're compassionate, and you truly care. And we couldn't be more honored to turn the presentation over to you right now. And we look forward to all of your updates. Thank you.
Thanks, Gina, for those kind words, and thanks for the invitation. Really appreciate the invitation from Shireen and Phil. And Phil has been, along with Shireen, a huge supporter of the Lyme Disease Research Center. And actually Phil's daughter, Nora Kenny, is on the advisory board for the center now at Hopkins. So this is really a core group of people that have made everything possible that we do. So I'm going to give you highlights of what I think are some of the important things that have happened in the last year in the Lyme disease field. I'll admit my bias. It's a little biased towards clinical events and clinical research, because that's what we do at the center, is we're a clinical translational research group. So as you all know, Lyme disease is a worldwide tick-borne infectious disease that continues to expand across the world, and has been recognized now for over 100 years, and it's not going away. In fact, recent publications have suggested that climate change may actually be one of the many factors that's leading to the expansion of tick-borne diseases and Lyme disease. So with warming trends and climate change, the range of tick-borne diseases is moving towards the poles in terms of geographic spread. It's moving up into higher altitudes and increasing in certain areas. It's also possible that it may decrease in areas that get too hot, but most of the trends favor expansion of tick-borne diseases, both in North America and Europe and Eurasia. So lots of factors contributing towards geographic expansion. This is a geographically expanding illness, Lyme disease, and all the tick-borne diseases. I'm mostly going to be speaking about Lyme disease, which is spread mostly by deer ticks or black-legged ticks, but I want to talk also briefly about Lone Star ticks, because this is an area that's actually a huge area of concern, that Lone Star ticks are expanding. So Lone Star ticks are geographically expanding as well, and you can see the huge range. We used to say they were in the mid-Atlantic area, but now they're north all the way up into Maine. I saw a publication last weekend reporting Lone Star ticks from the Dakotas. Lone Star ticks are important because they transmit different diseases than scapularis ticks. They're much more aggressive than deer ticks in the way they bite. They transmit infections like Ehrlichia and Stari, which stands for Southern Tick-Associated Rash Illness. And they're also associated with the alpha-gal meat allergy transmission. So a very important vector both of infections, but also a non-infectious disease. And this is expanding dramatically. The islands, Martha's Vineyard and Nantucket, are overrun with Lone Star ticks now, and you can see that they're really enveloping. So we've got more than just diseases transmitted by deer ticks. Transitioning to human cases of disease, counting cases is important, although fraught with error, but the most recent estimates that depend on insurance claims data suggest that we're approaching 500,000 new cases a year of Lyme disease. Now I'm talking about just Lyme disease, not all tick-borne diseases. Since that's a huge number and that's expanding, and it's a number you can only get by using data like insurance claims. The Hopkins School of Public Health has started a Hopkins Lyme tracker to try to track cases, because we know that the CDC reported cases at the 30 to 40,000 range is about tenfold underreported. So this Hopkins Lyme tracker at this link here I've given you, we're attempting to try to track cases and using different methods. I've shown you insurance claims in the last publication, but we're also experimenting with getting laboratory tests, Google search data, and looking for other ways to track cases, because you can see traditional CDC reporting doesn't work anymore. If you don't need more evidence of that, look at the state of Massachusetts. It's not that there's no cases of Lyme disease from Massachusetts, it's that the state of Massachusetts doesn't report cases anymore. So, you know, if the state reporting was bad before, it's only going to be worse in the future. So at this site, we're looking at new ways to track cases, because just like with COVID, if you don't know how many cases there are, you don't know what's happening. And if you don't know where the cases are coming from, you don't know where the new areas at risk are, as this geographically expanding disease continues to expand geographically. So tick-borne diseases, or these expanding geographic diseases, Ixodes scapularis, a deer tick, transmits a lot of diseases, but new ones besides just Lyme disease. This is Borrelia miyamotoi, a relapsing fever spirochete that's transmitted by the same tick that transmit Lyme disease. Powassan virus, a viral, rare, fortunately, but can be lethal infection. Anaplasmosis, related to Rocky Mountain spotted fever, and Babesia, the North American malaria-like parasite. All these infectious agents can be transmitted by this tick, and the tick can transmit simultaneously 2 or 3 infections with one bite. It's not impossible, and there are reports of Babesia, Anaplasma, and Lyme disease all transmitted from a single tick bite. Amblyoma, or the Lone Star tick, is a different tick, and it transmits different things. As I mentioned, Ehrlichia and Stari. These are the rashes of Stari. Southern Tick-Associated Rash Illness looks just like Lyme disease, but it's transmitted by Lone Star ticks. And then the alpha-gal meat allergy. So these ticks are important as well as deer ticks. So I'm going to transition now to clinical stuff. This is my chart on understanding the natural history of the stages of Lyme disease. Lyme disease is in its untreated form this is the classic outline that happens after a tick bite. The bacteria are inoculated into the skin from a tick bite. They multiply in the skin and the bacteria spread through the bloodstream. At the same time, there's a round red rash that almost never looks like this textbook bullseye lesion. It's usually just round and red, and it occurs in some, but not all of the patients during the time of the bacterial multiplication. Now, without treatment, that rash eventually goes away, actually. And then the second phase of the persistent infection is usually neurologic. And then the third phase, which occurs, these are months down here, on an average of 6 months later, is the late Lyme arthritis, which is actually the way the disease was originally discovered by Alan Steer in the town of Lyme, Connecticut. These stages of Lyme disease occur from untreated multiplication of the bacteria, first in the skin, but then after spread through the bloodstream to distant sites. So this is a persistent infection by a bacteria that knows how to persist in mammalian hosts. So let's talk a little about some of the changes in the diagnosis of Lyme disease and what's happening with diagnosis. We all know diagnosis is a huge problem, and it continues to be a problem. There's some changes I want to tell you about, though, that are important to know. First of all, remember that all these tick-borne diseases that I'm talking about look alike and are similar to other infectious diseases. In other words, all infectious diseases share symptoms of fever, chills, malaise, fatigue, and achiness. I love this picture. This was from early February 24th, 2020. This is one of the cabinet members of the Iranian government who's giving a press conference, and you can see him wiping the sweat away from his forehead during the press conference. Now, looking at that, you don't know what he has. He could have Lyme disease, he could have Ehrlichia anaplasma, but this was February 24th, 2020, and he had a symptom that's not listed here that is not seen in tick-borne diseases. He was also coughing, and he had COVID. So, symptoms of infection all look pretty much the same. And with just symptoms, it's hard to know what somebody has. And in fact, in the era of COVID, we've reported several cases now of people that were misdiagnosed with COVID that really had Lyme disease. So again, these symptoms of Lyme disease can easily be misdiagnosed as COVID. And just last week, I had another case of Lyme disease. This was the rash on the person's foot. She gave me permission to share this. She went into the doctors, this was last year, with this rash on her foot, and they told her she had COVID because they'd read about COVID toes, which looks like this, and said, oh, there's a rash on the toes. The person has a fever, chill, malaise, they must have COVID. But this doesn't exactly look like COVID toes, and the patient didn't have a cough or respiratory symptoms and turned out had Lyme disease, but it resulted in a delay of diagnosis for literally months until she had the right diagnosis. So diagnosis, don't let anybody tell you the diagnosis of Lyme disease is easy. I don't know if it's ever going to be easy. It's constantly a challenge. And so how do I approach the diagnosis? So the first question is, does the person have a rash? Because if they don't have a rash, all of these things look the same. So the first part in the decision tree is if they have a typical erythema migrans skin rash, you're in luck because you go down this side of the algorithm. And if they have a rash, you treat them. You don't need to worry about diagnostic testing necessarily. You've got a rash and you don't confirm the rash with labs because they're not sensitive at that early stage. And if they have risk factors for Lyme disease, you treat them for Lyme disease. You monitor for other tick-borne diseases, but you don't wait, you treat them for Lyme disease. So the key thing in everyone is always to see if they have a rash. And to look, I'll show you where to look. So yes, rash, great. But the problem is people still don't know what the rash looks like. So we're constantly amazed about how people don't know what the rash looks like. So this is a great publication by Allison Rebman and our group that looked at all the rashes because in our SLICE studies, which is now well over 200 to 300, looked at all these rashes because we have photos of all these hundreds of rashes, and she categorized them. And as you can see, some have the classic ring within a ring bullseye, but other ones don't. Some have a purple center, some are uniformly red, some have blisters in the middle, and she classified them by all these characteristics and then analyzed whether there were characteristics that were important. And two things fell out of this analysis. One is that men, their rashes were 2.2 centimeters larger than women's rashes, and that's after adjusting for duration of illness, and that the central clearing, this classic central clearing, was less common in older individuals, the older you were. So these bring up some really important points that, maybe diagnosis of the rashes is harder in women and harder in older people as well. So we're constantly learning about variability in disease and how important it is for patients and providers to understand the big variability in what the rashes look like. She also mapped out where the rashes occur, and you can see upper leg, abdomen, and my favorite to tell people about is behind the knee. 8% of the rashes were behind the knee, a classic location for the rash where you can't see it necessarily because it's behind your knee. So places you can't see, like behind your knee, your back, groin, are constantly being missed by patients and providers when they're looking for the rash. And then the area of recent interest that we're very, very interested in is the possible or probable failure to recognize rashes in dark-skinned people, African Americans, and other populations with dark skin. This is a man with his EM rash that was missed in the emergency room who went on to develop facial palsy and delayed diagnosis. There's been a recent publication this year that I'll highlight right now that was an insurance claims analysis that showed that African Americans had delayed diagnosis and were diagnosed at later stages of Lyme disease, including neurologic disease, presumably because providers are missing the chance to diagnose early in dark-skinned people because the rashes are harder to see. And frankly, we don't know what they look like. All the atlases and teaching material is missing examples in dark-skinned individuals. So this is another key area. If you don't see the rash or know what it looks like in African Americans, you're going to miss the chance for early diagnosis. And then the starry lesions look a little different than the Lyme lesions. They tend to be a little smaller, and they are less likely to have multiple lesions. They're more circular in shape. So recognizing starry from a clinical, practical point of view, it may not be a huge difference because starry is treated like Lyme disease, but it's important to know that this can be transmitted, is thought to be transmitted really more by Lone Star ticks. So rashes are crucial. If we don't know what the rashes look like, we miss the chance for early diagnosis when the prognosis is best. Unfortunately, not everyone has a rash. Some people don't have a rash. And if you don't have a rash, you got to go down this side where you don't know if the person has Lyme without a rash, or anaplasma, or babesia, or ehrlichia, or it's not Lyme disease, And so here we have to rely more on diagnostic testing. And unfortunately, the news on diagnostic testing in Lyme disease is still not great. We still don't get pathology or culture for Borrelia burgdorferi to diagnose. We still don't have great DNA PCR tests or protein antigen tests like the mainstays of COVID diagnosis. Those aren't really available yet for Lyme disease. And so they're under development. But again, Lyme disease diagnostic testing is still stuck with not great antibody tests. There are things in the works that are on their way potentially, but right now, the vast majority of people are going to get antibody tests, which you all know are indirect tests for the host response to the pathogen. They don't directly measure the pathogen by PCR or protein, and they don't culture or have pathology, the gold standards of diagnostic testing. So unfortunately, we're still at that phase of Lyme disease testing. There is a change, though. You all are probably aware of the two-step testing, which is the so-called standard two-tier testing, which starts with an ELISA screening test. And if that's positive, it reflexes to a Western blot. This is a Western blot with the bands. It uses IgM and IgG for the first 4 weeks. And then the recommendations are to use only IgG after 4 weeks. And the cutoffs are 2 bands for IgM and 5 bands for IgG. We all probably know the problems with Western blots. They were designed with specificity in mind for surveillance, so they're not great with sensitivity, and they're actually being transitioned out by most of the major laboratories now. So this old algorithm of the two-tier testing where you do the ELISA and then transition to the Western blots is actually being transitioned to replacing the Western blots with a second ELISA. So this is called modified two-tier testing, MTTT, modified two-tier testing. And that's what the most labs are going to now because it's much simpler and frankly cheaper and more reproducible than the Western blot testing. The problem is it's probably just as confusing because there's two ways to do it. The first test, the first tier is an ELISA or EIA, but the second tier, if the first tier is positive, can either be a combined IgM-IgG ELISA EIA, or it can be two separate ELISAs, an IgG ELISA and an IgM ELISA done separately. And if it's done that way, the 30-day cutoffs are still in play. So I don't anticipate that this is going to simplify things in patients or providers' mind, because they're still going to have to figure out which of the two second tier tests was done. And if it's the separate IgM and IgG, they're going to have to deal with this 30-day cutoff again. And frankly, the underlying biology that we're measuring here isn't really different. It's still dependent on the production of antibodies, which takes several weeks to happen. It's not perfectly sensitive, and it's not a direct test for the actual infection. It's not a PCR or an antigen detection test. So I wouldn't call this a huge positive revolutionary change, but it's a change, and patients are going to start seeing test results that look like this from the modified two-tier testing. So moving on from testing, let's go now a little more back to clinical, and we're going to start moving along the different stages of Lyme disease and talk about second stage, neurologic and cardiac. And if you look at the different stages that are reported to the CDC, you see the majority of reported cases are erythema migrans skin rash. But surprisingly, this is, contemporary data, a lot of people still get missed at those early stages and are reported to the CDC with late stages of Lyme disease, arthritis, Bell's palsy, neurologic, and cardiac. And I want to focus for a second on cardiac disease. I think cardiac disease is underreported probably because this case illustrates why. This case was a case report in the Annals of Internal Medicine from 2020, where a man presented with the disseminated skin lesions and fever and chills and systemic symptoms, and his cardiac involvement was not recognized because the symptoms of the cardiac involvement really weren't that specific. They were fatigue and palpitations, but nothing that was specific enough. But it was clear he had disseminated disease, and it wasn't treated promptly enough. And this patient actually died of cardiac Lyme carditis. So we think that Lyme carditis is still under-recognized and occasionally actually leads to sudden cardiac death. And short of that is probably causing unrecognized carditis. So Lyme disease isn't just skin disease. We still have all these organ system manifestations that clinicians have to be aware of. We're particularly interested in carditis because we're working with Adrian Baranchek and his group and cardiologists at Hopkins to start to look at patients in our cardiology clinics and to see if there's other manifestations of Lyme carditis that we're not aware of. This paper, not by us, but by another group, looked at Lyme disease as a predictor of atrial fibrillation. Now, if you ask an average cardiologist if atrial fibrillation has anything to do with Lyme disease, they'll say no. Although it's not unreasonable because remember, Lyme carditis involves the electrical system of the heart. This green pathways of the electrical system. So we know that Lyme carditis causes heart block by involving the electrical pathways, but it's really not considered a cause of atrial fibrillation. Although this paper recently published suggests that actually having positive IgG antibodies for Borrelia burgdorferi has an odds ratio of 8.2 to predict atrial fibrillation in this cohort. a stronger odds ratio than the known risk factors for atrial fibrillation, like heart failure and hypertension. So this is not widely recognized. We're going to start to study this with this group with Adrian and the Hopkins cardiologists. We're suspicious that unrecognized Lyme disease is leading to other cardiac manifestations, such as atrial fibrillation and possibly even idiopathic dilated cardiomyopathy. Although that's not known, it's something that nobody's really looked at. So more to learn always about the clinical manifestations of Lyme disease. So I'm going to transition now from, I've been talking about the textbook manifestations of untreated Lyme disease. I'm going to transition now to a tougher topic, but one that's near and dear to my heart, which is post-treatment Lyme disease. So here I've drawn a bunch of red arrows because the phenotype of post-treatment Lyme disease and the circumstances is that it typically, we believe, in many patients comes on after transition from these textbook manifestations to non-textbook manifestations. And it's often, although maybe not always, it's often in the context of previously treated, maybe not adequately treated, but previously treated Lyme disease that allows this post-treatment Lyme disease phenomenon to occur. And it has a slightly different phenotype, meaning appearance, than the classic textbook manifestations of untreated Lyme disease. So post-treatment Lyme disease, we're going to dive into that now because it's a super important topic. So let's start with what we call it. It's so controversial, as you know, we can't even agree on what to call it. It's gone through many name changes. Most recently, post-treatment Lyme disease, plus or minus the word syndrome, which is kind of a research case definition in our mind. Recently, many on the Tickborne disease working group talked about calling it persistent Lyme disease or persistent symptoms associated with Lyme disease. More recently, I've been likening it to long haul Lyme disease because of its similarities to long haul COVID. In some ways, I understand the controversy over the names, but I think what we want to agree on is that it's real and it's really important and it's a real disease. So what is it? So for purposes of research, this is the case definition we use. I'm not pretending this captures everyone that has the illness or any of the complications of Lyme disease, but for research, which is what we're going to be talking about here, this is a case definition that we use because we need to enroll people with a uniform case definition in our studies. So these are people that have the classic symptoms of cognitive complaints, fatigue, and pain. They have to be of significant severity that they impact function, so they can't be minor. They have to have received standard of care prior antibiotic treatment. Again, whether that's adequate is a question of controversy, but for the purposes of case definition here, at least have to have received standard of care, and they have to have been treated with standard of care for any recognized co-infections. They can't have a different disease that's causing their symptoms, like hypothyroidism or COVID, for instance. Interestingly, serology is not a part of the case definition. It's really based on evidence of a physician documented case of Lyme disease that preceded the onset of their chronic illness and persisted for at least 6 months. So that's the way we define it. And the big news I want to go into right now here is the study that you all know about called the SLICE study that we really started in 2008. We've really cut the data and analyzed it in a really a final way to answer our real research question. This SLICE study was set up to answer the question, is post-treatment Lyme disease as defined by our case entry criteria of people that present with the rash, get standard of care therapy, but then go on to develop chronic symptoms. Is it a real disease? And most important is it not due to other things? Because the critics of prior research had said, well, how do you know people with post-treatment symptoms, that those symptoms aren't just due to something else? Like they had an autoimmune disorder, or they already had chronic fatigue syndrome or depression, or they had a major illness that caused it like malignancy or hepatitis. So we designed the study to get around these previous criticisms. We excluded all these other look-alike diseases, and we required everyone have documented Lyme disease at entry into the study. Now you could criticize us and say, well, but then you only studied people that presented with a rash, and that's a valid criticism, but that gets to the issue of generalizability, which I'll talk about later. But importantly, this is the first pristine study that people can't argue about whether the exclusion and inclusion criteria were adequate to define the population. So we included everyone with defined Lyme disease with a rash at study entry, and then we followed the people over a year and defined post-treatment Lyme disease outcomes at 6 months after their treatment, because that's the case definition, that people would have symptoms at least 6 months following the standard of care therapy. And we split the outcomes in the 6 month time point into 3 groups. 57% of the people returned to their normal health. They had no symptoms or functional problems. 30% did have symptoms, but the symptoms had no impact on their health-related quality of life. So these 30%, many would suggest, and I would probably agree, might just have the symptoms that are common in the general population of minor to moderate fatigue, because it didn't impact their quality of life. But this was the group that met the case criteria. They had both symptoms, and the symptoms impaired their health-related quality of life. And it was 14%. So that's a significant number, because remember, these are people that were treated and diagnosed at early Lyme disease. These aren't people that had more complicated presentations. This is the best outcome you could probably have. And still 14% of the people had these symptoms at 6 months. So the critics would say, well, yeah, John, but how do you know that isn't the same rate as people that don't have Lyme disease? Maybe that's the rate in the general population. But this is the important part of the study. We enrolled controls at the same time. So controls had the same protocol, and only 4% of the controls had the symptoms and quality of life met the standard that the post-treatment Lyme patients did. So if you want to subtract 4% from 14, that leaves 10% of the people you could attribute their post-treatment Lyme disease to the fact that they had Lyme disease, and despite early standard of care therapy, we're still six months later. That's actually not bad, because our hypothesis was, and what we've said in review articles, it's 10 to 20%, and we hit 10% if you subtract out the 4. At the same time, actually, Gary Wormser's group from Valhalla did a similar study, although didn't use as rigorous a criteria for defining the symptoms as we did, but they actually got 20%. So I think the old quotes of 10 to 20% are still right, except for now, here's the study that proves it's true. A well-designed study employing controls with rigorous methodology to define their symptoms and quality of life. It's 14% of the people had post-treatment Lyme disease. So to me, this is a huge, important study. I think it should end the debate about whether post-treatment Lyme disease / long Lyme / persistent symptoms of Lyme disease / whatever new name we come up with. It should get rid of the controversy about whether it's real. Patients should not be told that it's all in their minds. They should not be told that it's just the background hum of life, of living. They should not be told that it's depression or anxiety. This is a real disease, and we've shown it in this study, and we're not the only ones that are starting to show this. It's interesting, because if you look at the symptoms of our patients that have post-treatment Lyme and the controls, when you look at this, they don't look all that much different. Fatigue in the patients, fatigue in the controls, pain. But the fake out was here is the severity of the symptoms in the Lyme patients is much higher. So if you only take moderate and severe pain in the Lyme patients versus the controls, you see there's a huge difference in moderate to severe levels of fatigue and pain and headache compared to the controls. And that's what people were missing. They were saying, oh, the symptoms are no different in controls and patients, but they are different if you look at the severity of the symptoms. And so our study showed that, not only was the symptoms more common than the controls, but they also were 8 to 15 times as high odds of having moderate to severe fatigue and pain. They had decreased health-related quality of life, in pain. And interestingly, there are increased rates also among females compared to males. So this is a study that I think should be the quoted study now, that post-treatment Lyme disease exists. It's a real phenomenon. If you go to our website, there's a nice video describing some of the nuances of the study. One thing I just want to point out again, that's a really important nuance, is in the real world, Lyme disease patients are often misdiagnosed and not treated early. In other words, they wouldn't qualify this study. So this study cannot be generalized to people that had complicated early misdiagnosis and inadequate treatment. In other words, the rates are probably, a PTLD are probably higher in the real world cases. And this is true for all research. You study cases that you can study, realizing that to generalize it to more complicated, messy real world situations, you're likely gonna have higher rates in the real world. So at a minimum, it's probably 10 to 20%, but it's probably higher in the real world of complicated medicine, where the diagnoses and treatment don't always go perfectly. So that study isn't over. The power of the SLICE study is that it now lives on. These 14% of people with post-treatment disease are now can be compared to the return to health in asymptomatic people, and compared using the blood samples that we draw. So these incredibly powerful blood samples in our biorepository are now the basis for multiple collaborations around the country to try to understand the biology of post-treatment Lyme disease. And we've already published numerous things using these blood samples showing differences between the post-treatment Lyme disease patients and the return to health populations or the controls. And we've shown that there's elevated levels of CCL19. We've shown different B cell responses in the patients. We've shown that gene regulation patterns are different in our patients than the controls. And we've actually used our samples and used them with other sites and other investigators and shown that the metabolome is different. So these blood samples that were collected as part of the study are an enormous resource for researchers that are now understanding why post-treatment Lyme disease occurs. What are the biologic markers that may be the future diagnostic tests or prognostic tests to understand post-treatment Lyme disease? These are examples of different gene regulation patterns that we're seeing in Lyme disease. You can see in pink Lyme disease patterns and how they're often different than bacterial infections or viral infections. And so there are certain gene regulation patterns in Lyme disease that are not shared by general inflammatory responses or viral infections or bacterial infections. And these gene regulation patterns are now the next phase that we're going to be reporting. We have a paper submitted right now and work that may also be the basis of future diagnostic tests looking at gene regulation patterns in the blood of people with post-treatment Lyme disease syndrome. Again, because of these blood samples from the SLICE studies. So what is the mechanism of post-treatment Lyme disease syndrome? I'm going to transition to that now and try to dive into the really tough question, is the why question. I think we've answered the what question. Post-treatment Lyme disease, long Lyme is real, it exists, it's not just in patients' heads. But now the why question is the why question, why? And there's really three main groups of theories. One has to do with persistent antigens or infections. One has to do with altered immune regulation and inflammation. And one has to do with altered neural networks and brain biology. And these three possibilities aren't mutually exclusive. And they're all viable mechanisms to answer the why question. Why do people after Lyme disease end up with these persistent illnesses, and what are the biology of what's going on? So I'm going to touch on all three of these. First, I'm going to talk a little bit about the relationship of persistent antigens and infections to immune dysregulation and make the case that they may not be unrelated. And this is a really important article that came out in the last year, published January 2022, by Bill Robinson. Bill Robinson is one of our collaborators, actually, that is at Stanford, and he published this paper that we're not part of, looking at a different infection, Epstein-Barr virus infection, and its impact on the eventual development of multiple sclerosis. And this gets at this idea that those top parts of the Venn diagram, that, you know, infection and abnormal immune response may be related, right? And this example in Epstein-Barr virus is a brilliant study that looked at Epstein-Barr virus, which we know is a chronic infection. If you've had mono due to Epstein-Barr virus, you carry lifelong Epstein-Barr virus infected B cells in your body for the rest of your life. And those infected B cells may, in Bill's paper here showed how, impact your immune system and lead to classic phenomenon of autoimmunity, such as molecular mimicry and B cell transformation. And these abnormal immune responses in multiple sclerosis may end up altering the immune responses in the brain, attack the myelin sheaths of your neurons, and cause the classic myelin pathology of multiple sclerosis. So an infection being manifested as a disease that's really an autoimmune disease, but was triggered by an infection. And so these infections can have long-lasting impacts that are independent of the infection itself doing the damage. In other words, Epstein-Barr virus isn't what's damaging the myelin. It's this autoimmunity that is triggering. These changes in immune responses can cause disease. So going back to our Venn diagram, in Lyme disease, maybe that's really one of the main mechanisms, is that persistent infection or retained antigen is triggering inflammation, but it's inflammation or altered immune responses that are doing the damage, not the bacteria themselves. So big paper, I think it has huge implications for how we look at the interaction of infections and altered inflammatory immunity responses. I'm going to transition to the third part of the Venn diagram, which is CNS, because this is an area we're doing a lot of work in now here at Hopkins. This paper, first by Brian Fallon, was a sentinel paper many years ago that looked at PET imaging in the brain of people with Lyme encephalopathy, what we would probably call post-treatment Lyme disease with cognitive symptoms or brain fog, you might call it. And these PET imaging studies showed hypometabolism in these patients with the brain fog of Lyme encephalopathy. So this is a huge paper that showed again that the patients containing that report Lyme brain fog, it's not just their imagination. You could say it's not all in their head, but actually it is in their head. There's a biology of it though. There's a biology causing the brain dysfunction. In this case, the PET imaging shows decreased metabolism, often in the frontal lobe. And these decreased metabolism areas are hypothesized to be the biology of what's causing the cognitive concerns and brain fog of the patients. So we've taken this work and taken it further, and we've just submitted a paper now describing functional MRI. So instead of just doing resting state imaging like Brian Fallon did, we're now imaging using MRI, but during activities. So these are parts of the brain lighting up in Lyme disease patients versus controls during actual, you could call this a stress test of your brain. So instead of resting imaging with PET, this is MRI during a cognitive challenge. So we ask people to remember letters and then manipulate the letters while the fMRI imager is taking pictures of the brain working. And you can see that there's areas of increased signal, which represents blood flow in fMRI, that's being triggered, and that it's requiring more areas of triggering in the Lyme patients than controls. So the Lyme patients, making it simple, are working a heck of a lot harder. Everywhere where you see red, the Lyme patients had to work activating those areas of the brain where the controls didn't have to. So Lyme patients on fMRI, they usually get their responses right, but it takes longer and they work a heck of a lot harder. And you can demonstrate that quantitatively on functional MRI. Again, proving some of the aspects of the why here. Why do patients with Lyme disease and post-treatment Lyme have cognitive issues, it's because their brain isn't working efficiently. They're having to recruit extra areas of the brain. They're working harder. There's a real biology underlying the symptoms that they're reporting. And then the ultimate question about the why we published on several years ago, I'm repeating it because it's such an important study and it'll probably never be repeated because it was such a difficult study to do. This was the brain PET imaging study. So we're going from PET that Brian did that looked at metabolism to fMRI now to PET imaging, but using a different chemical. So this PET imaging, unlike Brian's, shows inflammation in the brain. It doesn't show metabolism. It shows inflammation with a different chemical, which is very difficult to use and is only available in research settings. And it showed that there's inflammation in the Lyme patients' brains compared to the healthy controls. And this inflammation reflects glial cell inflammation that's, we think, part of the why the brains aren't working right, why they're having to work harder, is because they're inflamed, and inflamed glial cells in the brain make the brain sick and make it not work as well. So this may all sound academic to you, but now we're getting to a level that we are actually actionable because there are drugs and interventions that may come along in the future that are out there potentially to treat glial cell inflammation. So this as a mechanism is actually actionable. If we could trial and test drugs that impact brain inflammation, glial cell inflammation, you could potentially treat the mechanism that's underlying the cognitive symptoms. So it's not just an academic question, it's potentially an actionable mechanism of the illness and post-treatment Lyme disease patients. It also fits nicely with the hypothesis about what's driving some of the other symptoms we see. Remember, the brain here is complex. It's got the cortex, but down here is the brainstem. And the brainstem is where the vagus nerve lives and sends out its projections. And we're very interested in the brainstem as part of this brain illness and inflammation because the brainstem provides the fibers that go and control all of our autonomic functions. The autonomic functions are the automatic part of the nervous system that you don't have to think about. So these vagal nerve fibers go to your heart and regulate your heart rate and blood pressure. So right now, who's telling their heart what heart rate and blood pressure to have, right? Nobody, unless you're doing biofeedback, is telling your heart what heart rate to have. But your autonomic nervous system is doing it. That's why it's called the automatic system. These vagal nerve fibers are telling your heart how fast to beat and how to breathe. You're not thinking about how to breathe, how to digest. All these visceral organs are controlled by this vagus nerve. And interestingly, the vagus nerve is also sending signals back to your brain, to your limbic system that are telling you and impacting your emotions and behavior and memory. So this, we think, is a crucial nerve. And again, this nerve lives right down in here. That's part of where we showed there's glial inflammation. So if the vagus nerve is involved, this could explain some of the clinical phenomenon we see, because if the heart's involved, that may relate to some of the autonomic phenomenon, such as POTS and orthostatic fatigue. And the vagus nerve also gets fibers coming from your body back to the brain. And these also take pro-inflammatory signals from your body and feed them back into the brain. So it's a two-way system. And so it's getting also signals from your body. And if you've got persistent inflammation from the Lyme disease or the COVID or whatever else you have, it's sending signals back to your brain, that can also be driving this vagal signaling as well. So we got interested in this because of actually long COVID, where the people at Hopkins were seeing a lot of POTS in long COVID, and knowing that POTS may have its origin in vagal nerve stimulation abnormalities to the heart, we kind of put two and two together that maybe some of these symptoms in long Lyme, long COVID, chronic fatigue syndrome have to do with the vagal nerve dysfunction causing POTS. And so POTS is really an important part of chronic fatigue, as you may know, and now long COVID. So we think that's also potentially something in chronic Lyme that may be one of the underlying mechanisms. And again, it's an actionable diagnosis. So I want to talk a little bit about actionable things here, potential treatment directions. Again, that this isn't all just theoretical. If you diagnose POTS, it's actionable. You can treat POTS with different drugs and interventions. Brian Fallon's interested in treating it potentially with vagal nerve stimulation. The other things I want to talk a little bit about now in terms of potential treatment directions are also a really big news I want to give you this year in this talk. I've talked year after year about directions of therapy. I have to say now that we're finally, I think, getting ready to test some of these new therapeutic hypotheses in the Lyme centers. I mentioned Brian Fallon's interested in vagal nerve stimulation. We're actually interested in testing tetracyclines, which as an antibiotic, but they're also incredibly potent microglial inflammatory inhibitors. So when I showed you those glial cell activations on the PET imaging, tetracyclines actually calm that down and are anti-inflammatory basically for microglial activation. You may know about dapsone theories in treatment. Those are also antibiotics that are anti-inflammatories. And then there's pure anti-inflammatories. There's also, the potential role of the gut microbiome as a therapeutic intervention. And then we're very interested in the role of treating the brain dysfunction itself, either through mindfulness, or also you may know that the Hopkins Center in Psychiatry has done trials with psilocybin in the treatment of things like depression and post-traumatic stress disorder, and another way to impact brain dysfunction. So actionable areas that I think are actually getting close to fruition. Evidence of that is that the Cohen Foundation, you all know, is a huge supporter of Lyme disease work, has funded a Lyme Clinical Trials Network based at Columbia under the direction of Brian Fallon. Brian and I are good friends, and and colleagues and collaborators, and this Cohen Treatment Trial Network at Columbia has started now. It's got 3 sites: Brian's site at Columbia, a pediatric site at Children's National with Deborah DeBiase, and then a 3rd site at Green Spring Station where our center is. These 3 investigators are working actively now on planning actual pilot clinical trials, taking these laboratory and imaging observations and theories into actual clinical translational research, meaning real drug trials in real patients in our centers. And I can't give you the actual specifics of the trials because they're still under IRB review, but I can tell you between the 3 of us, there's 3 trials undergoing active IRB review right now that are going to be rolled out in the next year for treatment of long Lyme, post-treatment Lyme, persistent symptoms of Lyme, whatever your name we're going to use, you know what I mean. So in the meantime, there's also many things that patients can do along with the Lyme, Recovery Center. We're firm believers in Lyme disease recovery, involving the patient in aspects of recovery and wellness and health. And we're certain that what patients do to impact their health impacts their immune system, and that your health lifestyles are important, and that we take care of ourselves and our stress and nutrition and sleep and lifestyle in ways that can have a huge impact for how we recover from Lyme disease as well. I've become very interested in wellness approaches and what we have control over. This Japanese exercise, which translates basically to forest atmosphere or forest bathing, is a method of mindfulness, basically, that is very attractive, I think, to me, because it rings true as a way of biofeedback and changing neural networks that may be very helpful in what we can do as ourselves as patients. walking and talking with a friend. There are these types of things of mindfulness. There's a scientific basis for these, both in their impact on the immune system and their impact on this mechanism of what's called central sensitization. And there's new and emerging ways to impact these on a positive way. I like the idea of mindfulness in nature, although I don't like people standing in knee-high brush. So I'd prefer you do this, take a walk with a friend along a well-groomed path where there's no ticks. But there is something special about mindfulness in nature and in gardening that I think is an example of how we can impact our brain physiology ourselves without drugs. And I'm just going to end then with some prevention aspects because of course, in the long run, we want to prevent Lyme disease, although for people on this call now, I realize that it's often too late that we have Lyme, sequelae and active problems from our Lyme disease. But in the future, we also want to prevent Lyme disease. And there's really three big aspects: personal protection, environmental interventions, and vaccines. This is just a picture of a nice mouse getting a Lyme vaccine in their food. So there are trials right now, believe it or not, looking at vaccinating mice against Lyme disease to try to disrupt the natural reservoir vector of the animals that harbor Borrelia burgdorferi in the environment by vaccinating them with food bait. But the biggies for us to remember, and I'm really, this is so important to me because any of you that know me know that I'm a passionate gardener. So I would never tell anybody not to enjoy nature and the beneficial aspects of nature, but I would tell you that you got to do it in a way that protects yourself and your family. So I just want to review quickly some really important protection. One is avoidance of high-risk environments. So that means recognizing that even semi-urban areas can be high-risk environments. This is one of my favorite pictures in Mount Washington, Baltimore suburb, which is an urban suburb, but very green around corridors of streams. And to prove that, here's a school sign next to the deer crossing sign. So the kids and the deer both have the same crossing over this county, this road, which is really in suburban Baltimore. So recognizing high-risk environments, it doesn't just mean, out in the county and in parks. Much of the Lyme disease transmission occurs in what's called peri-domestic environments around your house in suburban environments. In your yard, we want you to create a tick-free zone where your kids are playing on the well-manicured part of your grass, and you separate that from the wild and wonderful nature that you don't go into, and you tick a chip barrier to try to keep the ticks in their zone and you in your zone, so you can enjoy your yard and garden in a relatively safe way. But nothing's perfect, so whenever I go out in my yard, I wear permethrin treated clothing. Permethrin for treatment of clothing, DEET for treatment of the skin. And this is my DEET treated pants just hang by my back door. And every time I go out to garden, which is usually twice a day, I put on my permethrin treated clothing. And then when I come in from the garden, I shower and do tick checks. And I love my pets, but I don't sleep with them. So these are things that you can do to enjoy the outdoors at diminished risk. Somebody had asked in the chat about vaccines. Actually, there's good news about vaccines too, I really believe. One is that Valneva and Pfizer are in phase 2 trials for a rejiggered OspA vaccine that is a broader vaccine, has more epitopes, is eliminated, they believe, the issue of the cross-reacting epitopes that was potentially involved with the alleged side effects of the previous OspA vaccine. So it's in phase 2 trials and with commitments and plans to move into phase 3 trials. So that's actually huge news about a potential human vaccine. As you know, there's still a dog vaccine, OspA dog vaccine, but there currently is not a human vaccine. But this could be available in the next several years. And then also very interesting is there's initial reports from Errol Fickrich's group about a tick vaccine. This is actually an mRNA vaccine, like the COVID mRNA vaccine, except here you're vaccinating to produce antibodies against tick proteins. And the antibodies made against the tick proteins, these are ticks attached to guinea pigs, not to humans. Guinea pigs get very exuberant inflammatory reactions to the ticks potentially. And so in the controls, you can see some inflammation around the tick bites, but in the vaccinated guinea pigs, you get this really exaggerated inflammatory response to the tick proteins that are being injected during tick feeding. And so the vaccine theoretically would cause this exuberant inflammatory reaction against the tick while it's feeding, and would cause the tick to either fall off or not feed effectively, or maybe more importantly, cause the person to itch and recognize the tick and identify the tick earlier, to remove it earlier, and then to be aware they've been bitten. So the nice thing about the tick vaccine is it's not specific to Lyme disease. It theoretically could protect against multiple tick transmitted infections. So this work in guinea pigs is very promising, that this mRNA vaccine induces tick resistance and prevents transmission of Lyme disease agents in guinea pigs. And this nice visual shows you the inflammation the vaccine produces compared to the control guinea pigs. So this is just in animal models, but again, exciting news that there are things happening in the vaccine area right now. So I'm going to end with a few announcements, shameless advertisements about our program at Hopkins. The first is our SLICE study still is ongoing, even though I presented you data that says that the first part is over in terms of proving that persistent symptoms persist in 14% of the patients, even despite early standard of care therapy. That part of the study is over, but the part of collecting blood samples to be used in diagnostic test development and for understanding the biology of the disease is still ongoing. So we're actively looking for people this Lyme season with early and late Lyme disease. For the early Lyme disease, we need people with active rashes that have not been treated yet. And for late Lyme disease, we need people with a positive IgG Western blot. Again, that doesn't mean that everyone that has late Lyme disease has a positive IgG Western blot. It just means for purposes of this study, that's the enrollment criteria. And we're also looking for healthy controls without a history of Lyme disease. So our research is ongoing, and we appreciate all the participants that have made this possible, now well over 200 in the 300 range. We invite you, if you're not already, to sign up for our newsletter that Nancy Doherty produces. It's been an incredibly important vehicle for education to keep people up to date on what we're doing in education. And then finally, we have another exciting announcement that starting this July, the Hopkins Lyme Center is starting a Tickborne Disease and Lyme Disease Fellowship program. And this is, I want to just pause and tell you how important this is. Everything I've been showing you today is what's called translational human research. Translational research is actually a very small fraction of the research that occurs in Lyme disease. Translational research means it involves human beings. In other words, it bridges human disease to science. And translational research, by definition, can only be done by MDs, right? Because as an MD, I can enroll, recruit, and care for patients, human beings, and enroll them in research projects. But a PhD can't do that, right? Because a PhD can't enroll and recruit patients because they don't see patients. They're laboratory PhD doctors. So translational research is actually a very, very, very challenging part of Lyme disease research. There's really only a handful of translational research programs in the United States because there's very few MDs that do Lyme disease research in the United States, or really in the world. It's very difficult to do, and there's actually a huge shortage of translational researchers. So we started a fellowship this year, which is really, I'm really excited about, because we want to train the next generation of MD translational researchers so we can do all these studies that we've been telling you about, to start doing treatment trial studies, which again, you need MD researchers to be part of. And it's an exciting next phase of what we're going to do. So if you know any medical residents out there that have a passion for Lyme disease, we now offer a 2-year fellowship for MDs that have finished their internship and residency. So this is our team that I want to thank. It takes an incredible amount of people spread across the university, including people at the labs at Bayview, School of Public Health, the Applied Physics labs, and then our core team at Green Spring Station and the Bayview Rheumatology Center. Our funders are indispensable. We're currently actively funded by the Stephen and Alexander Cohen Foundation. We have a DoD grant that funds our fMRI research, and a vast amount of our funding comes from individuals, including board members, individual donors, family foundations, and other Lyme advocacy groups have been essential in our early funding and getting us off the ground. And without all of these people, we wouldn't be where we are today. So thank you. And now we're going to transition it over to questions. Nancy is going to join me, and Nancy is going to provide questions for us to take our best shot at answering. And while I answer them, I'm going to put my advertisement back up there, and so you can write down the phone number. And Nancy, you can go ahead and start firing away.
Sure. Thank you, everybody, for the good questions. If you have additional questions, please put them in the Q&A. And we cannot answer specific patient health questions tonight, but if you have more general questions, please put them in there and we'll get through as many of them as we can. Thank you. So John, we have a question asking, what is the significance of your fellowship program being housed in internal medicine at Johns Hopkins?
Yeah, so the other thing, this would be the first, it actually is the first fellowship program ever established in an internal medicine department. Internal medicine is the core department that has all the subspecialties like infectious diseases, cardiology, GI. They're the kind of, they're the kind of master clinicians and subspecialists, and also includes general internal medicine, which are the generalists. But the significance is that's where clinical research is done in the medical school. These are the people that, do the COVID studies, that do, the studies. Frank, COVID's an example of being in internal medicine means we can collaborate our fellows with the COVID researchers and the long haul COVID researchers. So these are the people that really represent a huge bulk of the active research going on in infectious diseases and autoimmune diseases at Johns Hopkins.
Thank you. What can be done to improve the diagnosis of the Lyme disease rash in dark-skinned individuals?
So it's really the startling thing about teaching people to help them be aware of the diagnosis in dark-skinned people was having examples of rashes. It turns out, several people around the country have asked for examples, and all of the people looking for examples, I think we've come up with maybe 10, maybe 15 at the most total. And that's an extraordinary statement of how few examples there are to teach people. So when you're trying to teach people, there's not many examples to show them. The other area that's it impacts is we've been working on a app for cell phones to diagnose the rash on cell phone photos. And we've shown that actually using artificial intelligence, you can take a cell phone image and feed it into our AI application and diagnose the Lyme rash more accurately than people can looking at the picture, including physicians. So AI is an incredibly powerful way to make the early diagnosis of the rash, but it fails in one area. We didn't have any images of dark-skinned people to train the AI on. So, if you know anything about AI, it trains on thousands of images to train the computer what the image looks like. And we had thousands of images of Lyme rashes, but they're all in light-skinned people. So we can't train our app on dark-skinned people because we don't have any images. So we thought we were in trouble and all this work on the app was going to be for naught. But then the people at Applied Physics Lab were really way smarter than you think. They're actually training the computer to make images in dark-skinned people. So you may say, well, that's not fair. How can you use a computer to make the images that then you train it on? But it turns out they've done this already and it actually works. So the workaround is we're going to actually create images in dark-skinned people to train the computer on. But that's probably going to be the approach. But we still want more examples of real life photos of dark-skinned people because we need them to show our trainees and people what they look like. Because there's evidence, again, that African Americans are having delayed diagnosis because people aren't recognizing what the rash looks like in dark-skinned people.
So if someone has a photograph, what should they do with it?
Actually, this number that's up here right now, which is our research number, if you call that number and tell them that you've got an image that you might be willing to share, I'll contact you and reach out to you if you're willing to share it. You could call that number. That's just our main research number. Because we really are wanting more images to share with people to teach them. So yeah, you could call that number. It'd be great.
There's a question about just whether having Lyme disease might impact a COVID at-home test.
So, the current COVID at-home tests are antigen detection tests. So they're looking, primarily at the spike protein antigen. And those antigens are, remember, COVID's a virus. So, those antigens are very different than the antigens you'd see with a bacterial infection like Lyme disease. And it doesn't depend on antibodies. So having Lyme disease, which you might be asking, we know can affect immune processes. So even if it does, having Lyme disease changes your immune response, the home COVID tests don't depend on antibodies. They're antigen tests. So my answer is no, it shouldn't affect it. Measuring antigens should not be impacted by impaired immunity or being sick with Lyme disease. So I don't think that should be a problem. Same thing with the PCR nasal test at a hospital. Those direct tests don't depend on the immune response. So I think both those tests for COVID should work fine in Lyme patients.
What is the difference between Lyme encephalitis and Lyme meningitis, and are they treated differently?
So the encephalon, that's itis just means inflammation. So encephalitis is inflammation of the encephalon, which is your main brain. Encephalitis means inflammation and infection of the actual brain substance. Like those images I was showing you, the PET images, that was the actual brain. Encephalitis means the actual brain substance is infected. That's actually quite rare in Lyme disease. Meningitis, the meninges are the covering of the brain, the covering or the sac that contains the brain, the covering. Meningitis is an inflammation of the meninges or the sac. That's the more common aspect of neuroborreliosis. Meningitis is not uncommon. Encephalitis is pretty uncommon. And so the importance is either one of those means the central nervous system is infected and inflamed. And so the treatment needs to be more aggressive. Most people used to say it meant you had to get IV antibiotics. Although I'll tell you, there is a trend in pediatrics, especially about treating meningitis with oral antibiotics. And I'm not saying I agree with that, but it is a trend. And so the standard in my training was if you have central nervous system infection, it should be treated with intravenous antibiotics. But meningitis is much more common, the lining, than is encephalitis. So you may be asking, well, why do people with Lyme brain fog, if that's the brain, why do they have brain fog if the brain's not inflamed? And the answer is because the brain can still be impacted by the inflammatory molecules that are being released from the meninges that bathe the CSF that bathes the brain. Those inflammatory mediators like interferons and cytokines and chemokines can still inflame the glial cells in the brain without actually causing encephalitis. And I realize that's kind of a subtle distinction, but it's an important one. Your brain can be unhappy because it's being bathed by these inflammatory proteins, even though it's not infected itself.
Could the link between Epstein-Barr and MS be caused by Lyme disease suppressing the immune system, allowing Epstein-Barr to flourish rather than Epstein-Barr virus being the primary cause?
It's a great hypothesis. I think it's worth asking. And if it's worth asking, yeah, it's worth testing. That's a great hypothesis. I mean, nobody really, most people don't realize that everyone on this call right now it's had mono when they're a kid, has Epstein-Barr virus in your B cells. And the question is your immune system keeping them under control or not? We learned the hard way that if your immune system loses control of Epstein-Barr, it causes problems. We learned this actually with the AIDS epidemic. When the first patients with AIDS developed immunosuppression, part of that immunosuppression before treatments for AIDS were available, it was profound immunosuppression. It allowed their the patient's Epstein-Barr virus infections to go out of control. And that actually was one of the etiologies of lymphomas that spiked in AIDS patients. It was due to loss of immune control of Epstein-Barr virus infected B cells that allowed them to transform into B cell lymphomas. So it's not a bad question. I mean, suppression of Epstein-Barr virus infected B cells is the norm. That's what you're supposed to do. And if your immune system gets whacked, like in HIV, it clearly caused Epstein-Barr virus to cause then new problems. The question about whether suppression of Epstein-Barr virus by more subtle immunosuppression in Lyme disease, which is subtle compared to AIDS, comparing whether that could lead to then development of MS is a fascinating question. And Bill Robinson's research, I think, really opens that for discussion. These are unbelievably sophisticated studies to understand. And Bill Robinson's one of the kind of world-class scientists that could do that. The good news is we actually collaborate with them. So maybe I need to ask him on our next call.
Thank you. So the Venn diagram that you showed showing the different potential causes speaks towards Lyme disease's heterogeneity. And can you just comment on how the heterogeneity might contribute to the need for personalized medicine?
Yeah, so, I'm an infectious disease person, but our center's in the rheumatology division because rheumatologists are experts at heterogeneity, right? They have all these autoimmune illnesses that are very different, right? Lupus looks different than rheumatoid arthritis, looks different than myositis. And so I learned by being in the rheumatology division that the key to understanding complex illnesses is to understand that they're heterogeneous and that you have to create subsets to understand what's going on, because not everyone's the same. And I'm sure our audience knows that not everybody's the same. And so heterogeneity is key. And so our approach is to try to create subsets. And that's basically what you're saying, personalized medicine. If there are people in that Venn diagram that are going to have primarily an infection-driven or pathogen, driven process, that subset's going to look different than somebody who has primarily a autoimmune driven process. And that may look different than somebody who has primarily a central nervous system neural network process. And so the personalized medicine comes into finding biomarkers that can help create these subsets. We've already published one nice paper that looked at 3 subsets that fell out just based on symptoms alone, actually. And there seemed to be a subset of people with more joint types of symptoms that would look different on subset analysis than people that had more what I call the neck up symptoms, the brain kind of symptoms. And they fell out in a subset analysis. Again, kind of getting at this idea of, when we get these biomarkers worked out, that just like if you went to a rheumatology clinic, you'd get an ANA and a rheumatoid factor and a CCP antibody and all these biomarkers, and then you'd get subsetted into different types of autoimmune disease whose treatment is also personalized, right? The treatments for lupus look very different than the treatments for myositis or rheumatoid arthritis. So personalized medicine is a way of approaching this that rheumatologists are really at the forefront of. We have a new rheumatologist in our center, Dr. John Miller, who's an expert in autoimmune illnesses. It's looking at one subset, the people that develop arthritis on top of their long Lyme disease. So it is the future of how to approach this, because it's highly unlikely that everyone with long Lyme has the same balance of factors that's causing their illness.
One question from Canada, I guess, does your center consider Canadian residents for research studies in the clinic, or only US citizens?
There's nothing about where you live in the enrollment criteria, because the research is not billed to insurance. It's research participants aren't billed for their research activities. So for research purposes, no, there's no limitation. The only limitation is, the travel that it takes to, some of the studies like the fMRI studies last several days. So but we have people that have traveled from, all around the United States. So no, there's nothing about where you live.
So let's see. Have you seen a direct correlation with glial cell inflammation and patient-reported headaches?
So that's a really good question. The short answer is no, but you would expect that people with glial inflammation or CNS inflammation, one of the symptoms wouldn't be shocked or surprised if it were headaches. But we've not done a correlation study because the glial PET imaging studies are really complicated. And so we weren't able to study actual specific symptoms in those patients, but headache you would expect would be one of the symptoms for sure.
Are you aware of any research underway regarding some people being more likely to attract tick bites?
People bring that up to me quite frequently. And so I hear that a lot, makes me suspicious. We're not tick researchers, so we don't do that kind of field work. But the people like that are doing the tick vaccine work, there's a lot of people interested in what attracts ticks and the interface between environmental things and tick biology. So that's not something we would be involved in, though.
Is it possible to get infected with Lyme disease with mild symptoms and then go on to get some sort of autoimmune disease?
Absolutely, I think it's possible because, let me split it into 2 pieces. So is it possible to get mild Lyme disease? Absolutely. In fact, it's possible to get what you think is asymptomatic Lyme disease. I mean, you may have symptoms that are so trivial or so easily confused with a virus that you just blow it off as a virus and then they go away on their own. So we definitely see people that present to us with late arthritis that we know is a late manifestation who never had early symptoms that they recognized. So it's very possible to get early unrecognized Lyme disease. It's possible. And then the question is, can that then have its first manifestation as an autoimmune disease? I would tell you that I suspect that would be kind of after the person got treated that they develop the autoimmune disease. But remember, many people get treated for Lyme disease unintentionally. We see this all the time because remember, antibiotics are used so often in the general population for colds and sinus infections that we often see people that didn't really know they got treated for Lyme disease because they were getting antibiotics for a sinus infection, or they were misdiagnosed with cellulitis or something else and never knew they had Lyme disease, but they got an antibiotic for that or for an unrelated infection. And so they actually were treated, and then that's the milieu in which the autoimmune disorder might take then its footing. So I think there's often I get into a little bit of debates with people about, does post-treatment Lyme disease always occur after somebody's been treated? And I think we underestimate how many times people actually got treated and didn't realize they were treated because, think about it. I mean, how many times do people get antibiotics for unrelated things, presumably, that, might have treated a case of Lyme disease you didn't really know you had?
How does one find out about the upcoming trials, either at Columbia or Johns Hopkins or Children's National? And are there current studies that are working on biofilm disruption of Lyme disease?
So
bunch of questions
Dr.
about
Fallon has
trial.
an active study right now that's enrolling patients with I'm going to have a brain lapse here with disulfiram. So there's an active study at Columbia that's enrolling right now people for disulfiram trial. The studies that I mentioned that are in IRB right now, you'll likely be hearing about in the next few months. And the way to hear about them will actually be somebody named Nancy Doherty. I'll probably send out one of our email blasts and a special alert, because once the IRB approves them, then we can make them public. And so, and then the Clinical Trials Network, the CTN Network website at Columbia, if you just Google Columbia CTN Clinical Trials Network, Dr. Fallon, you'd get their website. They would also announce it. So I think those three ways you'll hear about it. If you're on our newsletter, Nancy and I will make sure we send out an email blast when we're allowed to. And I promise you that I think one or multiple of those will be announced this year.
Maybe you should put our newsletter slide up again, and then people can have time to copy down how you access that.
Yeah. Yeah, I'm very excited about these treatment trials. I've been wanting to do treatment trials for 15 years. I will tell you, they're incredibly complicated. And what I've been doing before, what are called cohort studies, where we don't test treatments. They're simple compared to treatment trials. So this is our first, it's very exciting time, and we're going to be getting into treatment trials, but they're very complicated. And they're extraordinarily expensive. Because you got to be really, we're giving people drugs, so these are not trivial experiments. We take it very seriously, but we're really excited because all of our translational clinical research, this is what we've wanted to do, is to have mechanisms that we could now test treatments for. So we're finally there, I think.
There's a few questions about POTS and EDS and whether there can be misdiagnosis for Lyme disease, or do they often occur? Does EDS make you more susceptible for Lyme disease or POTS?
So EDS, Ehlers-Danlos syndrome, I've learned a lot about this from Peter Rowe, who is an international expert on chronic fatigue, ME/CFS, and taught me a lot about EDS and POTS. So the issue is EDS and hypermobility is a spectrum, but the common thread is hypermobility. And so people with hypermobility, have that independent of Lyme disease. But if you have that, you're at risk for hypermobility of your neck. And if your neck's hypermobile, you're at risk for compression of your cervical spine, and where your spinal cord goes through your cervical spine. And that's that same area I showed you on those brain images at the base of the brain. That's where the brainstem goes into the spinal canal. And if your EDS allows you to be hypermobile, you can compress the cervical spine there. That's independent of Lyme disease. But if you happen to get Lyme disease on top of that, then you kind of have two hits, potentially for causing problems in that cervical spine area and the vagal nerve area. And so it's important to look for hypermobility in Lyme patient evaluations, A, because it could aggravate their Lyme disease, but B, that may actually be the cause of the patient's problem. If they have EDS and hypermobility of the neck, Peter and I have shared several patients where that actually turned out to be the whole cause of their chronic fatigue syndrome. And it really wasn't much to do with the Lyme disease. And there are rare cases where treating that will actually reverse the chronic fatigue syndrome. So Ehlers-Danlos syndrome is a really important part of the evaluation of somebody with fatigue, unexplained fatigue, basically. And having that and Lyme disease, would be. So that's sort of like having Lyme disease and COVID. That's why I always am really worried about my Lyme patients getting COVID, because I think, having post-Lyme and post-COVID is not a good combination, right? Because they both potentially can cause the same type of mechanisms that lead to autonomic dysfunction and POTS and fatigue symptoms. So I've learned a lot about EDS and hypermobility, and it's worth having as part of the routine evaluation for people with unexplained fatigue.
Excellent. There's more questions about traveling to your center to be part of a study, and perhaps from far away, and how long they would need to stay. I think it really depends on which study they're considering, doesn't it?
Yeah, but if you call that number, you can leave information. The key thing is, and I have to really emphasize this because I don't want people to be disappointed. A lot of people definitely have Lyme disease and chronic Lyme disease, but aren't eligible for the studies. So the issue of eligibility sometimes is an issue because the studies have to be designed with very specific eligibility criteria. But being out of state is not one of the eligibility criteria. I'll just say in general, that to be in one of the studies takes several days, but not several weeks. In other words, it doesn't take weeks to do this. We've had people stay like a week, I think, at the most for some of the bigger studies. But the first step is to see if you meet the eligibility criteria.
And then there's a question about, what about studying cohorts of Lyme disease patients relative to COVID patients and ME/CFS patients to try to tease out differences and similarities?
We're very, very interested in doing that. And so we have a couple projects that have been suggested that we're pursuing. One with ME/CFS with a group on the West Coast that we're exploring. And then for long haul COVID, exploring that with groups at Hopkins. So yeah, absolutely. We definitely want to do that. That's why we need more people in our fellowship program too.
And then another question about Lyme arthritis. How might changes in imaging technology benefit patients with Lyme arthritis?
Oh, that's so glad you asked that question. So John Miller, who's our rheumatologist, actually has brought joint ultrasound into our clinic. So, it used to be that when we examined people for arthritis, we were depending on our fingertips and feeling the joints and trying to find fluid, squishiness or bogginess with our fingers. John Miller has brought joint ultrasound into our clinic. So we now have joint ultrasound real time in clinic to find. And what we found is that joint ultrasound is way better than my fingers are. No surprise. This is always the case when you develop technologies for imaging. They're always better than the physician's old-fashioned physical exam. Even though I like to think the physician physical exam is still the end all be all, it turns out technology is actually better. So joint ultrasound finds joint problems that you can't feel with your hands. And so we have that now in John Miller's clinic as part of the, as you mentioned, personalized medicine approach, because if we see joint inflammation on his ultrasound, we then can hone in on that subset of illness and treat it more specifically. So that's a real asset. John Miller is really this is the first clinic, I believe, in the United States looking at chronic Lyme patients with joint ultrasound.
Can you talk about, with your fellowship program, what the 2 years encompasses, like what happens in the first year and what happens in the second?
So these are people that have finished their internal medicine or family medicine internship and residency. So they're licensed physicians that have finished their internship and residency. So in the first year, they actually see patients like with me by my side. So the first year is clinical training, where just like a cardiology fellow would, be next to a cardiologist in clinic, these people are next to me in the Lyme clinic, and they learn how to take care of Lyme disease patients at my side in the clinic here at Green Spring Station. And then the second year, they translate the bedside to the research area by doing a research training second year in the School of Public Health, where they learn how to be translational researchers so that they can join us and do all these great projects that we want to do. So the first year is clinical with me, and the second year is research in the School of Public Health, so that when they finish, they're a clinical researcher, they can get a job at an academic medical center doing clinical trials and doing clinical research, which we so desperately need.
Have you found a relationship between small fiber neuropathy and tick-borne disease, specifically Lyme disease?
I suspected it. Nev Zubrevnik proved it in a paper a year or two ago by looking at patients up at Spalding Rehab in Mass General that had what they suspected was small fiber neuropathy, and that publication was published a year or two ago that shows increased incidence of small fiber neuropathy in her Lyme patients. We'd always suspected it, but she's the one that did the study, and it's a good study. And the teaching point for physicians and patients is, nerve conduction tests with the needles that typically are ordered to evaluate numbness and tingling do not evaluate small fiber neuropathy. And so you have to order a different test. It's a skin biopsy for small fiber neuropathy, and it's a totally different test than nerve conduction studies. So we commonly find that people with numbness and tingling have been told they don't have neuropathy because their nerve conduction studies with the pins and needles were normal, but they never had a small fiber nerve biopsy. And if they have that, they can be abnormal, and then that establishes the cause of the neuropathy as a small fiber neuropathy, not a large fiber neuropathy. So really important point. I'm glad that question was asked.
Can you talk about the importance of listening to your patient?
Yeah.
And how that might impact your research?
Well, Alison Redman, our colleague here, a faculty member, we published one of the few and only and best qualitative research studies on listening to patients with chronic Lyme disease. And it's just a spectacularly beautiful paper that shows how important the doctor-patient relationship is, because if you can't listen to your patients and are unable to for whatever reason, you have a huge impediment to helping your patients, because you can't understand their illness they've been through from a diagnostic standpoint, but you also can't understand the illness they've been through from how it's impacted their life, and how to help them, you need to understand how it's impacted their life. That starts by understanding what they've been through and validating that they have a real illness that's not, again, I'll use this trite statement again, but it's so true, that it's not just all in their head, that you've listened to their story and understand that it's a real illness and that they're not making it up. That's probably the most important first step of listening to the patient, is validating that they're real and have a real illness, and that you understand how it's impacted their illness. And Allison's work showed that, that there's other things that come out of listening to the patients. You understand, what's gone wrong in their therapeutic adventure up to that point. And without understanding what's gone wrong, it's hard to know where to go forward. And so understanding that's part of listening to the patient. And then gaining the trust of the patient is important, because, as everyone on this call probably knows, treating chronic Lyme disease isn't just like take an aspirin for 10 days and you'll be better. It's a therapeutic, collaboration with the physician or provider and the patient. And so without having that relationship and gaining trust on both sides, you can't have that therapeutic alliance to help the patient.
Thank you, John. We're going to end on that note. I want you to know that we will be reading your questions. I'm sorry we didn't have time to get to all of them. And now I'd like to introduce Phil Kenny, who's one of the co-founders of the Lyme Disease Resource Center, now 6 years young. And Phil, thank you for you and Shireen for starting this really important support center. And we enjoy working with you. And I know that we've reached a lot of people, and hopefully the message tonight is one that brings hope to you all, that there are solutions that you can grasp currently, and there's solutions on the horizon that will help you heal. So Phil, I'm going to turn it over to you now.
Thank you, Nancy. And John, thank you so much for the in-depth presentation that you made in layman terms, so we can all understand it. You gave us a taste of the past, where we are today, and a glimpse of the future. So that gives us hope. And I said to you maybe 15 years ago, we can cope with hope and have the faith that something's going to happen in the future. And you've been such a key part of that. We thank you so much, and thank you for your time tonight. I want to thank Gina and Shireen too for their work on our projects. And folks, you can sign up, go to our website for our email distribution to get tips, continued updates on what we're learning. And the health and wellness brochure that John had on one of his slides is available from us. You can go to our website and see the PDF there, and then download that, or contact Gina and she'll send you a hard copy of both the wellness brochure and the daily wellness checklist. It really covers some good stuff on coping with this in body, mind, and spirit. It's a holistic approach. We highly recommend it. We want to thank those too that have been donating over the years. And for those who haven't, you can go to our website and donate, click on PayPal, send us a check. And we also have a relationship with Amazon. So you can sign up through our website on Amazon Smile, and every time you order, we'll get a little teeny percentage of what you order. So we thank you for that. And during this month, every dollar that you donate will be doubled. So if you write a check for $25, it'll turn into 50. So please consider a donation to pay for some of the things that we've done over the years and doing now, the background technical stuff that we do, brochures, information. So when you go to our website, you're going to be able to see this presentation again, because within the next, probably by the end of the month, we'll have this up there. So you can watch it again, let your friends know. There are also plenty of other previous presentations that have a great deal of information that are really good on your journey for living with Lyme. Come back next month in June. Megan Sims will be here talking about a diet. She's a registered dietitian. She's going to be talking about nourishing nutrition for optimal health and healing. It'll be great. I know she's fantastic. So join us. We want to thank you for being with us tonight, and we want to wish you well. Blessings to you and your family, and stay healthy. Good night.